What's up, Ninja Nerds? In this video today, we're going to be talking about valvular heart diseases. There's so much to cover in this lecture. Let's not even waste any time. Let's just get right into it and start talking about valvular heart diseases. When we talk about these, we have to have a basic kind of like bread and butter definition, kind of things that ease us into talking about valvular heart diseases. And that is understanding what happens when there is a valvular stenosis and what happens when there's a valvular regurgitation, because that's going to really build our foundation for everything we're going to talk about in this lecture today. So first thing we have to know is valvular stenosis. What does stenosis mean? So basically what I want you guys to understand is that the valve, and this could be any of the valves, it could be the mitral valve, the aortic valve, the tricuspid valve, the pulmonary valve, any of them. The valve itself is very fibrotic, it's very thick, and sclerotic, and calcified, and very difficult to open. Okay, that's one of the biggest things. So it's fibrotic, it's calcified, it's thick, it's very sclerotic, and it does not want to open and allow blood to flow in the direction that it's supposed to flow, from atria to ventricles, from ventricles to the arteries, right? That's the basic concept. That's what I want you guys to know. So the problem with valvular stenosis is there's some type of thickening of the valves which is making it difficult for a forward flow of blood. It's obstructing the forward flow from the atria into the ventricles, or it's obstructing the forward flow from the ventricles into the arteries. That is the basic concept. Now, if you have this issue where you aren't able to get blood flow from the left atria into the left ventricle, or the left ventricle into the aorta, that can lead to congestion of blood on that left side of the heart. And that can start causing it to back up into the pulmonary circulation, leading to pulmonary venous congestion. In the same situation, if you aren't able to get blood from the right atrium into the right ventricle, or from the right ventricle into the pulmonary artery because of a stenotic valve, that's going to cause congestion on the right side of the heart, backing up and causing systemic venous congestion. These are the big things to think about. Thick, fibrotic, calcified valve obstructing forward flow. If it's obstructing the forward flow on the right side of the heart, systemic venous congestion. If it's obstructing the flow of blood on the left side of the heart, it's going to lead to pulmonary venous congestion. All right. Now, to really hit this off, if the valves that are affected in sequence are the mitral valve, it can lead to mitral stenosis, aortic stenosis, pulmonary stenosis, and tricuspid stenosis. Now, in the opposite situation here, we talk about valvular regurgitation. So in valvular regurgitation, the issue is that there is a poor seal between the leaflets, right? So you know whenever you have the leaflets, the things that are supposed to snap together to prevent backflow of blood, normally these leaflets are not having a good seal, and it's causing a regurgitation of blood flow back into the original thing that was pushing it in that direction. What do I mean? If, for example, you're not supposed to be having blood going from the ventricles into the atria, it's doing that. Now there's blood backflowing in that direction. Or there's blood backflowing from the arteries into the ventricles. That's what's happening in these regurgitation problems. So whenever there's valvular regurgitation, that means that there's an incompetent, leaky, poorly sealed valve that's causing blood to backflow into the atria or backflow into the ventricles. Now, if that happens and blood backflows into the right side of the heart, it's going to cause systemic venous congestion. If it backflows and accumulates inside of the left side of the heart, it's going to cause pulmonary venous congestion. You guys get the point. So if the valves that are affected in sequence are the mitral valve, it can lead to mitral regurgitation, aortic regurgitation, pulmonary regurgitation, and tricuspid regurgitation. So now that we have the basic definition of what these are, stenosis obstructing forward flow due to a thick fibrotic calcified valve. Regurgitation is the backflow of blood across an incompetent, poorly sealed valve. These both can lead to systemic and pulmonary venous congestion. And we know the valves that are affected. Let's talk about what are the causes for those stenotic lesions and what are the causes for those regurgitant lesions for each individual valve, okay? So first one is mitral stenosis. When we talk about what are the things that makes that valve fibrotic, thickened, calcified, difficult to open, it is rheumatic heart disease. That's really the only one that I want you guys to know. Rheumatic heart disease is the most common cause for mitral stenosis. What happens is you develop a strep throat, right? You have streptococcal pharyngitis. So there's an infection of the throat. What happens is your body produces antibodies against that pathogen, but indirectly produces antibodies against some of the antigens on the heart and attacks the heart valves and causes fibrosis of the valves, narrowing of the valve lumen, and then obstruction of forward flow. Now, If that happens, we should know what are the particular things that put people at risk. And it's most common in the developing world, so look for any kind of immigration or traveling within the clinical vignette. But the other thing is it affects which valves in sequence. Mitral valve first, aortic valve next, and tricuspid last. It's very, very rare for it to ever affect the pulmonary valve. So again, rheumatic heart disease can affect multiple valves, affecting the mitral first, aortic next, and the tricuspid. All right, that's it. Rheumatic heart disease, mitral stenosis. Aortic stenosis. There's two particular things that I want you guys to remember. Bicuspid aortic valve can be one of the reasons for aortic stenosis, or a calcified aortic valve. And the difference between these two is the age. That's really the only thing I want you to know. So bicuspid aortic valve is what it sounds like. Normally, the aortic valve, if you actually take a cross-section and look at it, usually there's 3 cusps, 1, 2, 3. But in patients who have a bicuspid aortic valve, it's a congenital issue. So when they're developing and their valves are forming, there's a fusion of 2 of those 3 cusps. And now you have 1 cusp, 2 cusps. And the problem with having that is it makes it more difficult for the valve to open. So it makes it difficult for you to actually push blood out of the ventricles into the aorta. So when that happens, that's an important thing to think about. And if it's congenital, it's likely to be in the younger patients. We just use the cutoff as less than 70 years of age. Usually it doesn't actually come to symptomatic progression until about at least 50, but generally less than 70, you think bicuspid aortic valve. If they're greater than 70, it's likely they have certain risk factors. Their age, hypertension, high cholesterol, end-stage renal disease, any of those things increases calcium deposition and fibrosis of these cusps. Makes it more difficult for the valve to open, makes it less pliable, makes it more fibrotic, and not easy to open, obstructing the forward flow from the left ventricle into the aorta. These are the 2 ones that I want you to remember. But again, going back, rheumatic heart disease, what are the 2 most common valves? Mitral, then aortic, and then last is tricuspid. So you could potentially see rheumatic heart disease as a cause of aortic stenosis, but I want you to focus more on bicuspid aortic valve in less than 70, calcific valve in greater than 70 years of age. Okay, next one is the pulmonary valve. How can that bad boy get all stenotic and fibrotic and difficult to open and obstruct forward flow? The big one that I need you guys to remember is carcinoid syndrome. They may present this on your exam in a very specific type of vignette where you have a patient who has diarrhea. They have a rash, they have wheezing due to bronchospasm, maybe they have flushing of the face, and they also have pulmonary stenosis. What happens in carcinoid syndrome is there's a cancer, usually some type of neuroendocrine tumor that starts off in the GI tract usually, and then sprouts off, and they can actually go to the liver and then go into the right side of the heart. And what happens is these tumors, they increase a lot of the production of what's called 5-hydroxytryptamine, which is like a precursor for serotonin. What happens is all of this type of 5-hydroxytryptamine induces fibrosis of the pulmonary valve and makes it very stenotic, makes it very difficult to open, and obstructs the forward flow from the right ventricle into the pulmonary artery. So you have to be thinking about this in patients who maybe have bronchospasm, flushing, diarrhea, right? And they have some type of tumor of their gastrointestinal tract. Less common, but what can happen is sometimes the tumor will spread from the GI tract to the liver, to the heart, go to the pulmonary circulation, and then generally that may affect like the left side of the heart. But it's more common for this to be a cancer that is involving the GI tract and the liver to affect the right side of the heart, like pulmonary stenosis. So carcinoid syndrome, be thinking about that in the clinical vignette for a patient with pulmonary stenosis. Okay, the other one is called tetralogy of Fallot. So sometimes congenital heart disorders is really what I want you to think about. For pulmonary stenosis, it's usually also congenital heart diseases. So think about tetralogy of Fallot. Tetralogy of Fallot is based upon 4 particular findings. You have a VSD, you have right ventricular hypertrophy, you have a high riding aorta, and you have pulmonic stenosis. So if someone has tetralogy of Fallot, that puts them at high risk for pulmonary stenosis, because what are one of the 4 findings of tetralogy of Fallot? Pulmonary stenosis, right ventricular hypertrophy, VSD, and a high riding aorta. This is the 2 particular things that I need you to know for pulmonary stenosis. Let's talk about tricuspid stenosis. Tricuspid stenosis, super, super rare. You're probably not gonna see these on your vignettes, rarely ever. The ones that are gonna be more likely to be presented in your cases or in your exam are gonna be mitral and aortic. It's because they're more commonly affected. Pulmonary, not so much, and tricuspid, super rare. But for tricuspid stenosis, what I tell you were the valves that were affected in order: mitral, aortic, and what was the last one? Tricuspid. Tricuspid stenosis can happen whenever you have a very fibrotic valve due to antibodies that are attacking the tricuspid valve, causing inflammation, causing fibrosis of the tricuspid valve, and then narrowing the blood flow, obstructing the blood flow from the right atrium into the right ventricle, right? That's the basic concept. Very, very rare, way less common to affect the tricuspid valve, more likely to affect the mitral and the aortic valve, but think about it as a potential trigger in patients who have rheumatic heart disease. Okay. Now that we've covered tricuspid stenosis, pulmonary stenosis, aortic stenosis, and mitral stenosis, big thing, rheumatic heart disease for mitral, aortic, and tricuspid. Most common in mitral. Aortic, bicuspid aortic valve, or calcific, less than 70, greater than 70. And again, big one to think about for pulmonary is carcinoid syndrome and a tetralogy of Fallot. Let's talk about all of the regurgitations for the same valves over here. All right, so we talked about valvular regurgitation. There's a poor seal, right? There's a regurgitation jet that's going back from the ventricles into the atria or from the arteries into the ventricles. What is causing the poor seal? What is causing this regurgitation jets to form? Okay, first thing, mitral regurgitation, and we have to talk about this mitral valve prolapse. We're gonna add this one in there. It kind of goes along with it. So with mitral regurgitation, there's two types. There's primary and secondary. Primary meaning it's involving parts of the valve apparatus. What are the components of the valve apparatus? It's either going to be involving the valve leaflets, the chordae tendineae, or the papillary muscles. That would be the components of the valvular apparatus. So what are some diseases that can actually chew away or destroy or weaken the seal between the valve leaflets? That's a great question. One of them is called infective endocarditis. Infective endocarditis is a pathogen that loves to bind onto these valves and eat away and chew the valve. And if you chew away the valve, now you actually decrease the space or form a poor seal between the two leaflets. So if this one's shorter and this one's longer, now you have a jet that can fly right in between those and cause a regurgitation murmur, right? So that's one big thing. The other one, this is interesting. It's kind of like seems paradoxical in a way, but you know if you have rheumatic heart disease, really, really bad rheumatic heart disease, and it causes fibrosis of the valves become so less pliable, so fibrotic, not really wanting to move whatsoever. So this is in severe rheumatic heart disease, where these valves are so stiff where they don't open easily, but they don't close because they're so stiff and they just can't actually shut close. Even if you're having like the jets of blood whenever the ventricles are supposed to contract and snap those valves shut, they're so stiff that they don't even really want to come together and move together and slap together to close off that area. And so blood can jet in through that little area because of not forming that poor seal because of the excessive immobility of that valve. So you can see that in rheumatic heart disease. So those would affect your valve leaflets. What can affect the chordae tendineae or can affect the papillary muscles? I'm glad you asked. You know the papillary muscles, if they're connected to your myocardium. If you develop a myocardial infarction, you destroy or cause an infarct or death of the myocardial tissue near the papillary muscles, and that dies. Now the papillary muscles can rupture off of that dead myocardium. If they rupture off, what they're supposed to do is hold down in your chordae tendineae and hold them tight, keeping the leaflets nice and tight. But now, if you got that papillary muscle just hanging off, it's not going to keep the chordae tendineae tight. They're going to be loose, and they're not going to be able to keep that leaflet nice and taut. And so because of that, they may actually be a further distance from one another, creating an opportunity for a regurgitation jet. Okay? So papillary muscle rupture, destroying the papillary muscle and causing the chordae tendineae to malfunction. Or infective endocarditis, chewing away the leaflet, or rheumatic heart disease, causing so much fibrosis of the leaflets, they aren't mobile enough to close. One more thing is there's a disease that can affect the leaflets, the chordae tendineae, and even the attachments to the papillary muscle. And this is called mitral valve prolapse. So mitral valve prolapse is it's a condition in its own entity where there is a degeneration. So imagine these valves here are really degenerated. There's myxomatous degeneration, they call it. And when they're degenerated, they're very weak. Okay, very weak. So imagine you have a valve that's really tough, and whenever your ventricles contract, so here's your valves. Whenever you contract, they're supposed to slap together like this, right? But they're supposed to stay stiff like this and slap together to block the blood flow from coming between them. If somebody has mitral valve prolapse, this leaflet, the core of it is really weak. So whenever the blood is actually trying to snap the valves closed, for whenever your ventricles are trying to contract and slap the valves closed, it'll try to slap them closed, but then this thing's gonna buckle in because the actual valve, the core of the valve leaflet is really weak. And so it bows in into the actual ventricle. So imagine it like this. They're supposed to snap shut. They try to snap shut, but instead this guy bows because it's really, really weak valve leaflet. That creates a space here where the blood can't regurgitate back into the atria. So that's one reason. One is there's myxomatous degeneration of the leaflet in mitral valve prolapse. But you know what else is interesting? The chordae tendineae, sometimes they can be really weak. And this is associated with connective tissue disorders. So chordae tendineae are connective tissue. So what if you have less connective tissue or very weak connective tissue? Are the chordae tendineae going to be nice and taut and be able to keep that valve leaflets really nice and taut and close together with one another? No. So if you have a connective tissue defect and diseases such as Marfan syndrome, Ehlers-Danlos syndrome, osteogenesis imperfecta, where the chordae tendineae are really weak, they can't anchor those leaflets nice and taut. And that will cause them to, again, cause bowing of the valve leaflet into the atria during systole. And that can cause regurgitation. So big things I need you to remember for primary is there's a disease of the leaflet, infective endocarditis, rheumatic heart disease, chewing, fibrosis that makes it immobile. Papillary muscle rupture. You rupture off the papillary muscle, you can't anchor the chordae tendineae, they can't anchor the leaflet, that creates a regurgitation jet. Or mitral valve prolapse, which causes degeneration of the valve leaflet. It's weak and it can bow in during systole, creating a little space where blood can jet in. Or there's a weak chordae tendineae, which are supposed to keep the valve leaflets nice and taut, but there's a defect in them, Marfan's, Ehlers-Danlos. Okay? Then there is secondary mitral regurgitation. This is actually due to the other component, the annulus. So it has nothing to do with the actual leaflets, the chordae tendineae, or the papillary muscles. It's the annulus that holds on to most of the valve apparatus. If you stretch out the annulus, if you stretch that bad boy out, now you're creating a further distance. So imagine the annulus holds onto the leaflets, which connect to the chordae tendineae, which connect to the papillary muscles. If you stretch out the annulus, you increase the distance between the leaflets. Blood can just regurgitate back in. What are the conditions which can stretch the annulus? Heart failure, dilated cardiomyopathies. These are the big things to think about for mitral regurg. Okay, that was a big one. The next one's a little bit bigger, okay? Aortic regurgitation. Aortic regurgitation, again, there is a regurgitation jet that's coming from the aorta into the ventricles. Just like with mitral regurgitation, there was a regurgitation jet going from the left ventricle and to the left atria due to these causes. What are the things that are making this valve, the aortic valve, not form a good seal and leading to regurgitation jets? Well, there's two things. One is the valve is damaged or the aortic root itself is damaged. What are the things that damages the valve? If you chew away the valve in infective endocarditis, if you make the valve really, really fibrotic and less mobile where it can't actually close, regurgitation. And the next one, for some dang reason, a bicuspid aortic valve can put you at risk of aortic stenosis, but it can also put you at risk of aortic regurgitation. Figure that out. I don't know. But the basic concept is there is valve disease. Easy ones to remember: infective endocarditis, rheumatic heart disease. Infective, chew away the valve. Rheumatic, so fibrotic it's immobile and can't close. The other one to add on there is a bicuspid aortic valve. The thoughts behind this is that the bicuspid aortic valve is just more susceptible to infective endocarditis, but it's also more susceptible to calcifications, making the valve immobile, kind of just like rheumatic heart disease. So it kind of fits into both, increases the risk of infective endocarditis, and can also become super calcified and fibrotic and difficult to open and difficult to close, immobile, like in rheumatic heart disease. So it can kind of be like a little additional one just like both of those. Okay, but there's valve disease and then there's a disease of the aortic root. So if these valves are damaged and they're not working, that can create the regurgitation jet. But what if the aorta is super dilated, is really dilated, and it pulls, just like in secondary mitral regurg, you pulled the annulus. What if I pull the aorta farther outwards, pulling the valve leaflets or the cusp farther away from one another? That creates a space where blood can regurgitate. What are those? Anything that can cause an aortic aneurysm, my friend. Hypertension is a big one. Any kind of connective tissue disease where you weaken the walls of the vessels, they're more prone to dilate. That's connective tissue diseases like Marfan syndrome, Ehlers-Danlos syndrome. Or there's inflammation of the aorta. Anytime you inflame the aorta, it has the ability to also associatedly dilate. And this could be in things like syphilis, please don't forget that, ankylosing spondylitis. There's a lot of other conditions as well. Rheumatoid arthritis, SLE, there's a lot of different diseases, but I really just want you to remember inflammation of the aorta can cause aortic dilation, and particularly aortic aneurysms. The last thing that's just really interesting is aortic dissection. So this one I think is a little bit more complicated. So you know if you dissect, so a dissection is when you have a blood jet that maybe is supposed to move through the true lumen, and then it dissects through the intima into the false lumen. And what it does is it dissects down here. And you know that down here, there's little connective tissues that anchor the valve cusps, like annulus basically. What happens is that jet goes down and compresses on the annulus and makes the leaflet less able to keep its shape, and instead creates a weak leaflet. And now blood can regurgitate easily from the aorta into the ventricle. So aortic dissections can actually dissect through the wall, create a false lumen, and compress the annulus that holds the cusp, causing it to not form a nice structure, anatomical form, weakening or forming a poor seal, and now a regurgitation jet can form. These are the big things. I know it's a lot, I know it is, but mitral regurgitation, aortic regurgitation, mitral stenosis, aortic stenosis are really the big causes that you can't forget. So don't forget these. I know it's hard, I know it's a lot. Don't forget them. Let's come down and talk about pulmonary regurgitation now. Pulmonary regurgitation, very rare, okay? And really the most common cause, if someone had tetralogy of Fallot that caused pulmonary stenosis, they went and got a balloon valvuloplasty. And when they got the balloon valvuloplasty, they just dilated it. And balloon valvuloplasty is you take a balloon into that fibrotic valve and expand it, right? So you're just inflating the balloon and trying to puff out the opening between the tricuspid valve, pulmonary valve. So when you puff, 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 puff like a balloon to stretch it out, sometimes you stretch it out a little bit too much, that it actually creates a little pore seal between the pulmonary valve cusps, and you can cause a regurgitation jet. So this can happen after you cause a balloon valvuloplasty or repairing a tetralogy of Fallot problem. So they had pulmonary stenosis, right ventricular hypertrophy, VSD, high riding aorta. We're trying to dilate the pulmonary valve because it caused stenosis. And when we did that, it opened it up too much, caused a regurgitation jet. That's all I want you to know. Let's come down and talk about tricuspid regurgitation quick. All right, tricuspid regurgitation, super rare as well, but something to think about. When we talk about this one, again, it goes the exact same as mitral regurgitation. It's either a primary tricuspid regurg or it's a secondary tricuspid regurg. In other words, there's something wrong with the valve apparatus, whether it be the leaflets, whether it be the chordae tendineae, whether it be the papillary muscles. We have to think about what are the things that can damage that. Just like in mitral regurg, infective endocarditis, you chew the valve away, you create a poor seal, blood regurgitates. Rheumatic heart disease, you have excessive amounts of fibrosis of these valve leaflets to where they're so immobile and they can't dang near close. That creates an opening for blood to regurgitate. Another one is if you have carcinoid syndrome. Carcinoid syndrome causes fibrosis of the valves, right? Particularly which one? It would generally cause fibrosis of like the pulmonary valve, but it also can sometimes affect the tricuspid valve. And if you get a lot of fibrosis of that actual valve, again, just like rheumatic heart disease, it becomes immobile, not very pliable, and won't close. And so that could cause a regurgitation jet. The last thing is you actually rupture the papillary muscle. You have an MI. You have an inferior MI, it causes an infarct, ruptures the papillary muscle, can't anchor the chordae tendineae down, and then the leaflet blows back into the atria, doesn't give you a good seal, and then you just have a regurgitation. It's easy to remember, chewing the valve, infective endocarditis, less pliable valve, rheumatic heart disease, carcinoid syndrome, ripping off the chordae tendineae because of papillary muscle rupture, and then last thing is you stretch out the annulus. Stretch out the annulus, you pull the leaflets farther away from one another. What stretches out the annulus? Dilation of the ventricles, such as in right-sided heart failure, and this would be the example for that one. Okay, we covered the causes, we covered some of the definitions and the epidemiology. Let's now go into a lot of the pathophys and the connection between that to the clinical features and physical exam findings of all of these valvular heart diseases. All right, let's talk about the clinical features, physical exam findings now. So we're gonna go through each particular disease, mitral stenosis, mitral regurg, aortic, pulmonary, tricuspid, all of those, and talk about the clinical findings and the murmurs. These are the big things that we have to understand as the murmurs, really big. Okay, first thing, mitral stenosis. We know that there is a fibrotic, sclerotic, calcified valve obstructing flow from the left atrium into the left ventricle. This is the problematic issue. We can't get blood into the left ventricle as well. Now, because of that obstructive valve, the pressure in the left atrium builds up. Okay, when the pressure in the left atrium builds up, it can't go into the ventricles, so because of that obstructive valve, so it goes to the next direction, the lower pressure pulmonary veins. When it goes into the pulmonary veins, it congests the pulmonary veins and causes fluid to leak out, enough to cause pulmonary edema. And so that's one of the left heart failure symptoms, right? The other thing is if you have enough pressure that builds up in the pulmonary circulation, that can make it harder for the right side of the heart to have to pump against that edematous and filled of blood vessels within the pulmonary circulation. So that can cause pulmonary hypertension, because again, all of that fluid that's in the left atrium, it's such a high pressure, it goes into the pulmonary venous circulation. That can cause pulmonary edema. Enough of that blood in the pulmonary vessels can increase the pressure of the pulmonary circulation and cause pulmonary hypertension, which can then lead to right heart failure. So that's something to think about. So again, big thing, high left atrial pressure goes to the less resistant areas, lower pressure system. Pulmonary veins causes pulmonary venous congestion and pulmonary hypertension. So they'll have left heart failure symptoms. Because less blood is getting into the left ventricle, that may mean less blood actually gets pumped out into the aorta, but really that would actually not cause hypotension enough unless the patient has atrial fibrillation. Because you know what happens is whenever the pressure in the atria increases, the left atrium gets a little thicker and it contracts really hard to push blood down. It's called the atrial kick. And patients who have atrial fibrillation, they lose that atrial kick and they lose that extra volume of blood that goes down into the left ventricle. That means less stroke volume, less cardiac output, hypotension. So sometimes you can have a patient who can have hypotension. It's less common if they don't have AFib. But if they do have AFib, they lose that atrial kick and it's enough to cause less blood being ejected out of the heart. But I think the big key features is high left atrial pressure because of the obstructive valve, backflows into the pulmonary circulation, pulmonary venous congestion, and that can have some features of left heart failure and pulmonary hypertension. Second thing, because you can't push as much volume of blood from the left atrium into the left ventricle because this obstructive valve, what's that going to do to the volume of blood in the left atrium? It's going to increase. So then what happens is sometimes over time, to accommodate for all of that volume, the left atrium dilates, increases its size to accommodate for all of that volume. And when you dilate the atria, you stretch out the myocardial pacemaker cells and you agitate them and you create these ectopic foci, or you create little reentrant circuits that can increase the risk of atrial arrhythmia, such as atrial fibrillation, atrial flutter. And that's a problematic issue. The other thing is if you have this big old dilated left atrium and not as much blood is flowing through that stenotic valve, that means more of the blood stays within the atria. That's stasis of blood flow. What does Verco's triad say? Stasis of blood flow increase the risk of blood clots. And so you can get blood clots that form within the left atrium, and this can lead to embolization, so strokes. So big key features to remember for mitral stenosis is they can have pulmonary hypertension, they can have features of left heart failure, primarily pulmonary edema. They could have hypotension if they have atrial fibrillation. Because they dilate their atria, they can develop AFib, and because there's less blood that's actually moving from the atria to the ventricles, there's stasis in the left atrium, it increases the risk of emboli. And if they have atrial fibrillation, that also increases the risk of emboli, so they can pop off strokes. These are the big features. Now, we have the basic kind of things. So if a patient presents with shortness of breath, dyspnea, right? They present with orthopnea, shortness of breath laying flat, paroxysmal nocturnal dyspnea, difficulty in holding, actually they have shortness of breath when they're sleeping at night, right? They have AFib, they have palpitations, they have visible AFib on their EKG, and they have strokes. These are things to be thinking about for mitral stenosis. But here's the thing, go to the patient, get that stethoscope, listen. When you look at their heart, what is the problem here? Go back to your pressure curves. So here in green is going to be the atrial pressure, right? And what we have here is we're going to have the pressure curve for the aorta, the pressure curve in orange for the left ventricle, and the pressure curve in green for the left atrium, okay? When we look at these pressure curves, I want you to correlate it with the heart sounds, S1 and S2, okay? What happens is you see how the left atrial pressure during S1, okay, you're gonna have this little rise here of the left atrial pressure, and then it should go down, and then you get a little bump there. What happens is whenever the ventricles start to squeeze and contract, right, they squeeze and they contract, they shut the mitral valve and the tricuspid valve closed. So right here, you should close the tricuspid valve and the mitral valve. That would give you the S1 heart sound, okay? Now this entire time period is going to be ventricular systole, that entire time period, all of this. Then what happens is, as your left ventricle ejects blood out into the aortic pressure rises, and then what happens is you get this thing called the dicrotic notch. And that usually is going to be kind of around the time where you would shut you get a brief rise in pressure because you snap shut the aortic and the pulmonary semilunar valves. And that should correlate with S2. So the aortic valve and the pulmonary semilunar valve should be shut. When those shut, the mitral valve and the tricuspid valve should open. And that would happen because the atrial pressure should be higher than the ventricular pressure. So look, it is. What happens is you try to snap open that very tough, fibrotic, very sclerotic valve in patients who have mitral stenosis. And when you pop that thing open, it makes this thing called an opening snap. So it would occur right here whenever you're trying to open up that mitral valve and tricuspid valve. When you try to open it up, it's so fibrotic that it creates a little snapping sound. And then blood is going to try to squeeze through that narrow opening down into the ventricle. And when it does that, it makes this very interesting type of look. You see how this is kind of going down in intensity? Look, they look the same, right? This right here is going down in intensity. So as blood is actually, once you open the valve, it snaps open, a lot of blood rushes through that area, and then less blood, less blood, less blood, less blood, less blood, and less intense sounds. So we call that a decrescendo type of configuration. So what we see in these patients is they have a murmur that occurs in diastole, right after S2, when we close the aortic and the pulmonary valve, so it's right after S2. It starts with an opening snap, and that's due to opening up that fibrotic, calcified, stiff valve, mitral valve. And then after that, it's followed by this decrescendo diastolic rumble. That is the big thing to remember for these patients with mitral stenosis. Now, where would you hear it? That's the other thing. You want to hear a diastolic murmur. It needs to be decrescendo in fashion. It has to have a rumbling type of appearance to it. There is no usual radiation, but when we listen, we want to hear left, fifth intercostal space, mid-clavicular line. This is where we would be listening. If we hear that, and this features, along with these clinical exam findings or features, this would be somewhat suggestive of mitral stenosis. All right, mitral regurg. So now we have a very poorly sealed valve. We have an opportunity for blood to regurgitate. Where is it going to regurgitate from, my friends? It's going to regurgitate from the left ventricle into the left atrium. Now, when that happens and we have this reflux of blood back into the left ventricle, that increases the pressure in the left atrium, right? Because you're refluxing all this blood back into the left atrium, which it doesn't want to have. It's like, dude, I can only hold on to so much volume. You're going to increase my pressure, bro. And so it starts increasing the pressure in that left atria. Again, where does blood like to flow? From areas of high pressure to low pressure. So it sees the pulmonary veins and it's like, here you go, take this blood. And it pushes the blood back into the pulmonary veins, causing pulmonary venous congestion. How does that look like? It may cause pulmonary edema, so some features of left heart failure. It may cause the blood vessels in the pulmonary system to get higher, more filled, and increase their pressure. And so then you can have pulmonary hypertension, which can start causing right-sided heart failure symptoms. These are the big things to think about. The other thing is, think about this. When your left ventricle is supposed to be contracting, it's supposed to push blood in this direction, not up here. So now imagine here that you have a certain stroke volume, let's say 70 mLs. Out of the 70 mLs that you're trying to eject out of the heart, you only eject 40 out into the aorta. That's what you're normally supposed to push 70, right? But let's say that out of this, you only push 40 out into the aorta and you push 30 back into the atria. You just lowered your stroke volume. You didn't push out as much volume as you're supposed to be pushing out from the left ventricle into the aorta because you push some of it back into the left atria. So you lose that volume in the aorta. So you decrease your left ventricular stroke volume. You drop your cardiac output, and that can cause hypotension. So you can see this in patients, especially if it's an acute mitral regurg. Now here's what's really interesting is that sometimes if this happens acutely, you can have someone with significant pulmonary edema, significant hypotension, so acute symptoms of left heart failure. If over time, all of that volume that they keep accumulating, because they're not going to eject out as much. So you know eventually whenever that blood goes into the left atria, it's going to go right back down into the left ventricle. It's eventually going to the left ventricle is going to keep getting blood that it pushes back into the left atria. Because every time the left atria receives this blood, it might push some into pulmonary circulation. But guess what? Once the atria have to fill the ventricles again, it's going to donate that blood back. And so the ventricles will get filled and filled and filled. And this can increase what's called their left ventricular end-diastolic volume, just how much blood they have in their ventricle before they contract. If that happens, they try to compensate for that. So it doesn't increase the pressure in that left side of the heart and keep causing more venous congestion. And it'll dilate their left ventricle to accommodate that. That can happen in chronic cases, okay? But this is the big thing to remember in acute cases. They can develop acute hypotension, pulmonary edema, and they might have this murmur that we're going to talk about here in a second. In chronic cases, they may be asymptomatic because they dilate their ventricle, their left ventricle, to accommodate that volume, less pulmonary edema, less hypotension in that sense. All right, so we have this patient here who has mitral regurg. What are we going to do? Well, we're going to go get that stethoscope. We're going to listen to their chest. And again, think about the pressure curves here. So here's your left atrial pressure in green. Here's your aortic pressure in blue. And then here is your left ventricular pressure in red. Whenever somebody, again, goes through their process here, right, at this point right here, when the ventricular pressure, the red line, goes above the green line, the atrial pressure, that's enough to close the mitral valve and the tricuspid valve. And that'll begin the onset of S1. So that's going to be when the tricuspid valve closes and the mitral valve closes, right? That's supposed to be when it happens. And then that begins the onset of ventricular systole. Normally, your mitral valve is supposed to close at S1. But guess what? All the blood that your left ventricle is trying to push into the aorta, guess who else is pushing it back into? The left atria. And so now the left atria is getting filled. What happens to the pressure inside of the left atria? It goes up. So all of this time is during the reflux. The pressure inside of the left atria is increasing because it's just getting refluxed with all this volume of blood. So during that time period, right whenever the tricuspid and the mitral valve are supposed to close, that begins the onset of ventricular systole. All that blood is regurgitating into the atria. That's causing a turbulence of blood flow and leading to this murmur. That's when you'll see this. So it's a holosystolic murmur. It starts right at the onset of ventricular systole, right after S1, and goes all the way until you get to S2. So that occurs right here when the aortic valve and the pulmonary valve close. It's supposed to open up the tricuspid valve and the mitral valve. And then again, right there, that will begin the onset of S2. At that point, then the mitral valve is already open and blood will just flow back down. But this right here is a holosystolic murmur. It's the entire time period of ventricular systole. Blood is just regurgitating right from the left ventricle into the atria. So that's what you would have here. And when you're looking at the same place for mitral stenosis, left fifth intercostal space, mid-clavicular line. But what happens is in this situation is you're ejecting blood from your left ventricle back into your left atria as going towards your axilla. And so in this situation, they would have a radiation to their axilla. The other thing is this would be a murmur that's more like blowing in intensity, very loud, very musical type of murmur. And again, it's a systolic murmur. This is a diastolic murmur. This is going to be kind of keeping somewhat of the same intensity. Sometimes it has a slight crescendo type of effect here. It might have a slight crescendo, but for the most important part here is that it's occurring throughout the entire time period of systole. All right. The other thing to think about is you can have that patient with the mitral valve prolapse. And there is a separate interesting entity that you have to be able to pick out on this one that's not just mitral regurg by itself. Remember, MVP could cause mitral regurg, right? What happens in this condition is, remember I told you, when the ventricles contract, they're supposed to shut the mitral valve and the tricuspid valve close. But if you have a degenerated mitral valve, myxomatous degeneration, or a weak chordae tendineae, what happens to that actual valve leaflet? It bows inward during systole. So whenever the ventricles contract, it's supposed to bring these leaflets together, but it bows them. And when it bows the leaflet, that bowing of the leaflet creates the clicking sound. And you'll hear that. So they'll have this like early to mid kind of systolic ejection click. Actually, it's a mid-systolic ejection click. So here's their ejection click, and that is the bowing of the mitral valve leaflet. Then, once you bow that, you create a little space where there's a pore seal. What can that do? Cause blood to regurgitate into the left atria from the left ventricle and produce a murmur. And that's a mitral regurgitation murmur. So sometimes if you hear a click and a mitral regurgitation murmur, you should think about a mitral valve prolapse. If you hear just a continuous holosystolic murmur at the left fifth intercostal space, midclavicular line radiating to the axilla, you should think about just a primary like mitral regurgitation. But if there's a click associated with it, it might be a mitral valve prolapse. And there's maneuvers we can utilize to change the click to come earlier, come later, the murmur to be shorter, to be longer, and we'll talk about all of that, I promise. But these are the big things to think about for mitral regurgitation. Now that we covered that, we went over mitral stenosis, mitral regurg. Let's go over the aortic stenosis and then aortic regurg. All right, aortic stenosis. Now this one is very interesting, right? So there's, again, some type of obstruction of blood flow. The aortic valve is very stenotic, it's very fibrotic, it's very immobile, it doesn't want to open, doesn't want to allow blood flow to be able to exit out. So it's causing an obstruction of blood flow to go from the left ventricle into the aorta. There's an obstruction of blood flow. We can't get the dang thing out of there. Okay, what we would say is, because that valve is so stenotic, it's so fibrotic, it's very difficult for me to get blood flow out of the left ventricle. That would be equivalent to somewhat of saying there's a higher afterload. We're making it harder for the left ventricle to be able to eject the amount of blood that it needs to or wants to out into the aorta. Because this valve is decreasing the diameter, it's making the resistance to blood flow much harder, and it's causing the pressure to be higher across that valve. And so now I have to work harder to be able to get the left ventricle to push as much blood out. So we call that afterload, okay? So afterload is the amount of resistance that is being provided that's making it harder for the left ventricle to have to pump blood out, right? So it's the amount of work that the left ventricle has to do to overcome the pressure or resistance in the aorta. That's how we define it. If that afterload is high, that means that the pressure that's going to develop within the left ventricle is going to increase, okay? It's going to increase the left ventricular pressure if the afterload is going to be higher. What happens is when the left ventricle is under higher pressure because it's having to push against a very stenotic valve, it gets really mad and it starts going to the gym and it starts just bench pressing and getting thick and increasing the size of the ventricle. It's going to undergo left ventricular hypertrophy, and it's going to get really, really concentric type of hypertrophy, making the left ventricle very, very thick. When that happens, and you thicken up the left ventricle, there's very specific symptoms that can develop. One is, imagine the left ventricle is very, very hypertrophic, right? So you have a very thick left ventricle, and now you have this left ventricle trying to push blood out of the heart against this very stenotic, very, very tough valve, okay? When that happens, think about the particular symptoms. One, if I'm having difficulty pushing blood out of the left ventricle and up to where? Up to the brain. There's less perfusion, there's less amount of blood that's getting into the carotid circulation, going to the brain. This can lead to syncope. Loss of cerebral perfusion for a small period of time, they can actually syncopize. All right, that's one particular thing. The second thing is if the ventricles are really, really hypertrophic and very thick, they're going to have a higher demand. We're going to need more blood to be able to be supplied to that muscle and need more oxygen. If they're very thick and you're also not ejecting as much blood out because of that narrow stenotic valve, that's lowering the coronary perfusion. That can lead to anginal chest pain. You know what worst case scenario that can happen? It could be so little blood flow that it can actually cause sudden cardiac death in these patients. That's a big thing to remember. Not enough blood flow to the myocardium can cause significant ischemia, enough that it can cause a fatal arrhythmia and cause them to go into sudden cardiac death. The next thing is if the left ventricle is super, super hypertrophic and you're actually having difficulty being able to, again, have that problem of being able to deliver blood to your actual systemic circulation to help you to be able to move and perform all the certain types of activities that you need to, what can happen is you can actually become very short of breath, and specifically with exertion. How can you remember these very important clinical features in aortic stenosis? It's SAD. SAD, syncope, angina, and dyspnea. These happen primarily in these patients with exertional activities. That's the big thing to remember for these patients. All right, that's one thing. The second thing here that's very important is with all of that afterload, again, you got that very thick fibrotic valves, making it difficult for blood to be able to get out of the left ventricle, okay? So there's a high afterload, Okay, your left ventricle is under a lot of afterload, a lot of resistance that you have to overcome to push blood out into it. When afterload increases, stroke volume decreases. If there's less blood that's getting out into the aorta, less blood filling the carotids, that's going to cause the pulse that you should feel when you feel the carotid pulse to be not very strong. It's going to be diminished. That diminished or decreased intensity of the carotid pulse is called parvus. So there is a diminished or decreased or lower carotid pulse. The other concept here is if there's a high left ventricular afterload, your left ventricle is going to have to generate a lot of pressure to push blood across that stenotic valve. So it's going to have to generate more pressure, contract harder. That's going to take a little bit more time. And so that delays the amount of blood that's getting out of the left ventricle into the aorta. That means less blood is getting into the aorta a little bit later, delayed left ventricular cardiac output. Less blood is actually extending or stretching out the carotids that induce that pulse. And so it's taking a long time. It's coming later. It's tardy. And they call that tardus. So the combination of a decreased or diminished carotid pulse and the pulse coming later is called parvus et tardus, which is a very common pathognomonic finding in aortic stenosis. Okay. The next thing we have to talk about besides the sad symptoms, the parvus et tardus, is the murmur that you can have in aortic stenosis. What happens is, again, here's your aortic pressure in blue, here's the left ventricular pressure in red, and here's your left atrial pressure in green. We really want to look in the comparison between the left ventricular pressure and the aortic pressure. Now, the left ventricle is going to really work hard to push as much blood as it can into the aorta, but it's underfilling the aorta, right? Remember that. You're not getting as much blood out of the left ventricle because the afterload's so dang high. Afterload increases, stroke volume decreases. You're not getting as much blood out of the left ventricle. So the aorta gets underfilled. So look, the aorta should actually be equally filled in comparison. If you have good stroke volume, all the blood that's being pushed from the left ventricle should fill the aorta. If you guys looked at the other diagram over here, like look, it's filling every blood pressure that the left ventricle exerts should equally distribute into the aorta. But because of that stenotic valve, I'm not equally distributing that pressure. And so there's a lower pressure within the aorta. It's underfilled. Now, if that happens then, now you have all of this space. That's going to give you an interesting type of murmur, okay? Again, S1 is the onset of when the ventricular pressure overcomes the atrial pressure, it snaps shut the tricuspid and the mitral valve. That would begin the onset of S1. Then you have your dicrotic notch, which is the closure of the aortic valve and the pulmonary semilunar valve. That would begin S2. Now, the other way that we can describe S1 is you're closing the tricuspid valve and the mitral valve, and you're opening, which valves? The aortic valve and the pulmonary semilunar valve. If the aortic valve is supposed to open, you shouldn't hear any sounds between whenever that aortic valve opens to whenever the aortic valve closes, correct? It shouldn't actually have any sound between there. All you should hear is the closure of the aortic valve, and that's it. You shouldn't be able to hear the valve opening or blood spurting through it in between systole. That's not how it's supposed to happen. But whenever the left ventricle is ejecting, it makes it so difficult to push blood through that stenotic valve that it makes a little clicking sound because it bows the valve a little bit. It bows the valve a little bit, and then we shoot a ton of blood out. And look at the configuration of this curve here. Look at this pressure curve. What does it look like? It's starting off, less blood is flowing through, then more blood is flowing through, then more blood is flowing through, then less, then less, then less. You know what that configuration is called here? Crescendo, because it's increasing in intensity, and then decrescendo, decreasing in intensity. That is the big thing to remember. So in these patients, their murmur begins right after S1. It's a systolic murmur, okay? And it gives you first a little ejection click right after S1. It's an early ejection click. Then after that, you have a murmur which is crescendo, decrescendo, and fashion. And this murmur is very important to remember. Let's talk about where you want to listen and where it radiates next. We have this patient who has an early systolic ejection click with a crescendo, decrescendo murmur, right? We think it's aortic stenosis. Where would we listen? You want to go right, second intercostal space, parasternal border. That's generally where you would have your aortic valve. So you want to hear that. Then the next thing that you want to listen for is, does it radiate? Generally in this type of murmur, when it's harsh, it's a harsh type of murmur in comparison to regurgitation, which is more of a blowing, musical type of murmur. you'd want to listen for radiation, particularly into the carotids. Usually the radiation is the direction which the blood is flowing. So for example, in mitral regurgitation, it was flowing from left ventricle into the left atria, towards the axilla. In aortic stenosis, it's flowing from the left ventricle into the carotids. And so you should have radiation of that murmur in the carotids. That's a big thing to be thinking about. So they have, again, heard of the right second intercostal space, parasternal border, and it can radiate to the carotids. It's a big, big thing. One of the big ones that differentiates this between hypertrophic obstructive cardiomyopathy. The next thing here is, what are some other findings that we have to add on? They just love to add these on the boards. Is that, you know, whenever your left ventricle, remember I told you that bad boy's getting all kinds of thick. It's working out, it's getting jacked, and it gets super thick. It causes that concentric hypertrophy. That's left ventricular hypertrophy, right? So now we have left ventricular hypertrophy, and you actually decrease the diameter of the lumen of the left ventricle. When you decrease the diameter, it actually can kind of increase the pressure inside of that cavity now. So with that high hypertrophy and high pressure, imagine now this poor little left atrium has to push blood into this jacked left ventricle. It's going to be so difficult because this left ventricular pressure is so darn high. So what does it have to do? It has to go and do some weights. It has to get a little jacked up a little bit and start thickening up. And so it undergoes left atrial hypertrophy to accommodate for all of this high pressure in the left ventricle. When it undergoes hypertrophy, guess what? It causes this very interesting type of phenomenon. So you know whenever S1 occurs, that's the closure of the mitral valve and the tricuspid valve. And then S2 is the closure of the aortic valve and the pulmonary valve. What happens is, during diastole, when blood is supposed to be filling into the heart, it does it in 3 phases. There's rapid diastolic filling, which is the early phase. There's mid-diastolic filling, which is just the continuous blood that was in these channels here. So rapid is that the blood was in the atria, fills down. Mid-diastolic filling is it's within the vena, the superior and inferior vena cava, and they're just moving into the atria, into the ventricles. Late diastolic filling is when the atria contract and push blood down into the ventricles. Well, this atria be all kinds of jacked now. It's like Jay Cutler or Ronnie Coleman out there. Lightweight, baby! And what happens is, when it decides to contract, imagine this hypertrophic, jacked left atrium contracting down in the blood. It's going to really squeeze that blood down into the left ventricle. And we call that the atrial kick, and it's way louder than usual. And that kick that occurs in late diastole, right before the S1, is called the S4 heart sign, and it's characteristic in aortic stenosis. That's the last thing that I wanted you guys to know for this one. Let's now talk about aortic regurgitation. All right, so aortic regurgitation. All right, here we go. We have a patient, they have a poorly sealed aortic valve, but it's supposed to be going, right, from the left ventricle into the aorta, should not be going back from the aorta into the left ventricle during diastole. But that is what is happening. So there's a damaged valve or aortic root dilation, or aortic root disease of some kind, that's causing a regurgitation of blood flow back from the aorta into the left ventricle. So there's left ventricular regurgitation or reflux. What is the complications of that? When you reflux all this blood from the left ventricle back, from the aorta back into the left ventricle, now you cause all of this blood to accumulate in the left ventricle. And now this is going to cause it to backflow from the left ventricle into the left atria. That's going to increase left atrial pressure. Whenever the pressure in the atria is higher, it likes to go to the area of lower pressure, sees the pulmonary veins, pushes some of the blood there. Causes pulmonary venous congestion. So you may get features of left heart failure such as pulmonary edema. If the pressure in the pulmonary artery starts building up and building up from all of this congestion, it can cause pulmonary hypertension, which can subsequently lead to right-sided heart failure. That's one thing. The other thing is, every time you reflux blood that was supposed to be in the aorta, which contributes to your cardiac output, your stroke volume, you reflux it back down into the left ventricle, you drop your stroke volume. Think about it like this. You want to push out 70 mLs of blood into the aorta, right? That's your stroke volume. If you push out 70 mLs, 40 of it stays in the aorta and 30 of it refluxes back down into the left ventricle. What was your true stroke volume? 40 mLs. So that's a drop in your stroke volume. If you drop your left ventricular stroke volume, less blood is filling in the aorta. That drops your cardiac output. That drops your blood pressure in the actual systemic circulation. That's going to cause hypotension, sometimes to the point of cardiogenic shock, especially if it's acute. So just like an acute mitral regurg, where you can develop acute pulmonary edema, acute hypotension with cardiogenic shock, the same thing can happen in acute aortic regurgitation. One of the big things, though, is just like mitral regurg, if the left ventricle dilates, because you're going to have all of this blood, everything's going to keep filling back into the left ventricle, overfilling it, causing pulmonary edema. If the left ventricle dilates to accommodate all of this blood, there's less pulmonary venous congestion and less of that hypotension, right? And so because of that, that would happen in the more chronic types of cases. So in the chronic cases, they usually are maybe a little bit more asymptomatic, non-specific symptoms, no significant pulmonary edema, no significant hypotension. But if it's acute, they're likely going to have pulmonary edema, hypotension, and some nasty murmurs that we can have here. Okay, here's something that we have to go on a little bit more with. This one's really, really interesting. So not only can the patients have acute heart failure types of symptoms, but this is really interesting. So let's say that we go back to this patient with a chronic aortic regurgitation, and they're accumulating all of this volume, right? Remember what I told you, when they accumulate all this volume, they don't want to keep backing it up into the left atrium and into the pulmonary circulation, so they dilate their left ventricle. When you dilate the left ventricle, you make it bigger. If you make it bigger, it can accommodate more volume. If you have more volume in the left ventricle before you contract, what is that called? Preload. I up my preload. What is the relationship between preload and stroke volume? Assuming that your contractility is normal and your afterload is constant. It's going to increase stroke volume. So an increase in preload will increase my stroke volume. That means I'll push more blood out into the aorta. Some of it may reflux back down, but I'm pushing more volume of blood into the aorta. That's one particular thing. So the amount of blood that I'm pushing out into the aorta during ventricular systole is going to be higher. Some of that blood may reflux back down, yes, but the amount of blood I'm squeezing out into that aorta is going to be higher because I'm overfilling my ventricles, increasing their preload, increasing their stroke volume, increasing the cardiac output, increasing the systolic blood pressure. Now here's where it gets a little interesting. When I push that blood into the aorta and I fill the aorta, the systolic blood pressure will go up. But then what happens is the aorta goes into diastole. It accommodates that volume of blood and then recoils. When it recoils, some of the blood will go back down to the ventricles. In normal patients, it'll shut the aortic valve and no blood will go back in. But in this patient, they have a damaged aortic valve, or they have an aortic root disease. That doesn't happen, and now the blood just regurgitates. When that blood regurgitates back down into the left ventricle, there's less blood in the aorta now during diastole. Less aortic filling during diastole drops your diastolic blood pressure. Now, what is it called when you take your systolic blood pressure minus your diastolic blood pressure? It's called your pulse pressure. The pulse pressure in these patients is crazy wide. They have such large pulse pressures because their systolic blood pressure is so crazy high because their left ventricle is just slamming blood out into the aorta. The aorta is getting filled during systole, but during diastole, because of that incompetent valve, it's just slamming back into the left ventricle, dropping their aortic pressure during diastole. And so their diastolic pressures are super low. So you would have a patient who would have like a blood pressure, let's just to give you an example of like 220, I'm exaggerating this, but 220 over 40. That is an insane difference in comparison to someone who has like 120 over 80, right? So this is a huge difference, but these are the kinds of pressures that you would see. Now, that could be one finding as you're looking at the blood pressure and you're like, holy crap, what the heck? Why is their systolic like through the roof and their diastolic is so darn low? That could be one particular finding. The other thing is physical exam findings that they love to ask you on the exam. One is you take a look at the carotids. Now, whenever the ventricles contract, they're smashing blood into the aorta and then filling the carotids quickly during systole. So whenever they have systole, their carotid is going to bang, it's going to pulse out. They're going to have a very quick distension of their carotid artery. But then the aorta is supposed to go into diastole, and what happens is the blood just gets refluxed back down into the left ventricle. So what happens to the aorta? Pressure drops. It gets underfilled. And so all the blood that was in the carotid circulation gets yanked back down into the aorta and back into the left ventricle. And that causes a very sudden drop or collapse of the carotid. And that sudden rise and sudden collapse of the carotid is called Corrigan's pulse. And so that's something that you can see, or Corrigan's sign. Other things that you can see is a water hammer pulse. So you take and feel their radial artery, it's bounding, it's blasting rapid, distension and then collapse. And then you lift their arm up and you'll actually see this being accentuated, a rapid distension of the radial artery and then a rapid collapse whenever you lift their arm. Other things you may see is a pistol shot pulse. So you'll feel like a boom, boom across the femoral artery, and that's again due to the systolic and diastolic pressure differences. And other things that you may see is the uvular pulsations, or Mueller sign. You can literally see the uvula, that little punching bag in the back of the throat, kind of pulsating. There's a bunch of other things like Quincke's sign and de Rosier's, a bunch of them, but I think that these are some of the big ones to remember: Corrigan's, water hammer, pistol shot, and uvular pulsations. Okay, cool. So we have the findings of acute heart failure, wide pulse pressure findings. What else? It's that murmur, baby. We got to listen for the murmur. So in this patient, again, go ahead. Aorta is the blue, left ventricle red, left atrium green. Again, we're looking pretty much at the left ventricle in the aorta, okay? So right here, whenever the left ventricular pressure overcomes the left atrial pressure, which is in green, that's going to shut the tricuspid and the mitral valve closed. That'll give you your S1. Then all the way from S1 to S2 is ventricular systole. The aortic valve is opening. It's working well to open and push blood out. But the problem is during diastole, it's supposed to close. It is not. So what happens is, here's your dicrotic notch, right? So the dicrotic notch is supposed to kind of signal the sign of a closure of the aortic valve. But this aortic valve is not closing very well, okay? It's actually going to be having regurgitation jets flow in. So normally what should happen is it should fill easily. The left ventricle will push blood out into it, and it's going to push blood out into it, and the aorta is going to accept all of that blood. But then what should happen is it should have this dicrotic notch, and then again have a kind of, it should actually kind of look like this, really. And then it should go into the next cycle. But look at what happens to the pressure in the aorta during diastole. So right whenever the aortic valve closes and the pulmonary valve closes, we start the onset of diastole. So right here, we should begin ventricular diastole. Ventricles are only supposed to get filled by the atria from, across the left atrium to the left ventricle, right atrium, right ventricle. But now this aorta is filling the left ventricle, unfortunately, because the aortic valve is incompetent. It's not having a good seal. And so the blood is just shifting back into the left ventricle. It's dropping the aortic pressure like crazy. And so now look at the aortic pressure. It drops significantly when it's supposed to be going this way. Okay? So now we have this big kind of like difference in the curve right here, where it kind of like looks like this, where the intensity looks like it's decreasing as you go throughout the process of diastole. Oh, what is that called? We have a murmur. It starts right at the onset of S2. Right after S2, the aortic valve and the pulmonary valve are supposed to close. They don't close fully. Regurgitation jet comes back into the left ventricle, and it decreases in intensity throughout the process of ventricular diastole. We call that a decrescendo type of murmur. And these patients, they have a diastolic decrescendo murmur that is blowing in intensity and in quality. Now that we covered that, let's talk about where you would hear it, where it radiates to, and the other findings down here that we have to mention. When we're listening for these patients who have aortic regurgitation, we're going to be listening again where the aortic valve is, right second intercostal space, right? So we're listening right around that right second intercostal space, peristernal border. And what we're going to be listening for is a diastolic decrescendo type of murmur, blowing in quality, very loud, high, usually grade 3 or above. And what we're listening for here is, where does it radiate? Well, again, you have to think about the direction of the regurgitant blood flow. It's going from aorta down to the left ventricle. So the aorta would be right around here on the right second intercostal space, but the regurgitation jet is moving towards the left ventricle, which is towards like the left nipple. So it's going to be moving this way. So it radiates to the left sternal border. So if you hear the murmur here at the right second intercostal space and it radiates to the left sternal border, that should make you be thinking about aortic regurgitation. The next thing that you want to be thinking about here is this it kind of goes opposite of what we talked about with aortic stenosis. In these patients and chronic patients, they dilate their left ventricles, right? So they dilate their left ventricles to accumulate more of to accommodate more of the volume. Now, If they dilate, they can take in a lot of volume very rapidly in the early phases of diastole. So you know in diastole, again, whenever blood's coming down into the atria, it comes down in 3 phases: rapid, diastolic filling. So that's whenever the blood that's sitting in the atria, the tricuspid and the mitral valve open, and blood quickly, rapidly flows down. Then you have the mid-diastolic filling, where it's the blood within the venous channels. They're just waiting to get into the atria, and then they move down to the ventricles. And then late diastolic filling is when the atria decide to contract and push the remaining amount of blood that's into them down into the ventricles. These are the phases. In patients who have very, very distended, compliant left ventricles, very distensible, stretchable ventricles, or very large ones, they're going to be able to take in a ton of blood during the early phase of diastole. So during the early phase of diastole, they're going to be able to have a rapid flow of blood that moves into the ventricle and will just bang off the wall and produce all of this turbulent blood flow. That will produce a murmur. Turbulent blood flow will produce particular murmurs. But it happens right whenever the atria push blood down to the ventricles, right when they open in the rapid phase. So if you think about it, S1 is the onset of ventricular systole. S2 is when there's beginning of ventricular diastole, right? So this is whenever they're supposed to be getting filled with blood from the atria. Right in the early phase, you'll hear this low-pitched murmur. And that low-pitched murmur is due to the rapid diastolic filling producing a lot of turbulent blood flow banging off these dilated ventricular walls. And that is a S3 heart sound. S4 heart sound was the atrial kick from the left atrial hypertrophy. Big difference between these two, have to remember them. Okay, let's quickly talk about the murmurs that you will hear in patients with pulmonary stenosis and regurgitation, tricuspid stenosis and regurgitation. And remember that their clinical features are primarily some type of right heart failure symptoms. We're going to focus primarily, though, on the murmurs. All right, let's hit these murmurs now. So we only got tricuspid and we got the pulmonary ones that we got to go over. And really, I only want you guys to focus on the murmurs. That's all I want. They may have right-sided heart failure symptoms, so they may have some JBD, they may have some hepatomegaly, some ascites, some pedal edema. But I think the big thing is knowing the murmurs, just because they're not super common, like ones that you might see in your question stem. So I kind of want to quickly go through them, but talk about them to be thorough. So pulmonary stenosis, again, when you think about this, it's just like aortic stenosis. All of these are going to be just like the ones that we talked about. So in pulmonary stenosis, you're going to have difficulty being able to get blood flow from the right ventricle into the pulmonary artery. It's going to kind of snap open and make it difficult to click open or bow open the pulmonary valve. That'll produce a early systolic ejection click. Then a lot of blood will actually start to flow out. So you get a crescendo. Less blood will leave, decrescendo. So it's exactly like aortic stenosis. You're going to get a systolic ejection click with a crescendo, decrescendo murmur, except it's going to be heard at the left second intercostal space, parasternal border, and there's really no radiation that's listed in the literature that's significant here. Okay? That's it. That's all I want you to know for pulmonary stenosis. For pulmonary regurgitation now, it's exactly like aortic regurgitation. You have the pulmonary valve that's incompetent, it's not having a good seal. So blood will backflow from the pulmonary artery into the right ventricle. When it does, it'll backflow and there'll be a ton of blood initially that flows through and less over time. And that's going to cause a diastolic decrescendo murmur heard at the left second intercostal space, parasternal border. That's all I want you to know. Let's talk about tricuspid and tricuspid regurgitation. All right, so tricuspid stenosis, it's exactly like mitral stenosis. So again, with this patient, you have a very stenotic, fibrotic tricuspid valve. Difficult to get blood flow from the right atrium to the right ventricle. When it does, you cause an opening snap right after when? It's going to occur right during the beginning of diastole, right after S2. So you'll have an opening snap followed by a diastolic decrescendo type of rumbling murmur, just like mitral stenosis. The only thing is that you would hear that at the left fourth intercostal space, parasternal border. Finally, tricuspid regurgitation. It's just like mitral regurgitation. So this is really just a review and a recap of the murmurs, right? It's pretty good. With this one, again, the tricuspid valve is incompetent. It's not forming a good seal. Blood is backflowing from the left ventricle into the left atria during systole, and is occurring throughout the entire time of systole. This is a holosystolic regurgitation murmur, blowing musical in intensity, heard at the left fourth intercostal space parasternal border. That's it. That's it. That covers all of the types of valvular heart diseases, their clinical features, their physical exam findings. What I really need to take you guys through now to really understand this is how we can really differentiate some of these murmurs. So there's a lot of maneuvers, there's a lot of positions that we can put these patients in to accentuate the murmur or increase the intensity of the murmur or decrease the intensity of the murmur, and that can help us aid in our diagnosis. Let's talk about those. All right, so here we go. This is a very high yield point that we have to talk about, guys. It's gonna come up in the clinical vignettes no matter what. So we have to understand these different maneuvers that we can utilize to accentuate particular murmurs or decrease the intensity of murmurs, okay? So first things first, I think we got a good way of being able to memorize these and remember them in an easy, systematic process, and also go through some of the pathophysiology through it. All right, first thing, inspiration. How can this change murmurs? Okay, inspiration, think about this. You take a deep breath in. When you take a deep breath in, your intrathoracic pressure drops because it's trying to drop so that you can pull air into the lungs. But when your intrathoracic pressure drops, what happens is it actually creates like a vacuum effect and sucks blood from the abdomen and from the neck, superior inferior vena cava, sucks blood down into the right side of the heart. So it increases the blood flow into the right side of the heart. That means more blood flow flowing across the tricuspid valve and more blood flow moving across the pulmonary valve. Anytime you have more blood moving across those valves, that's going to increase the intensity of any murmur associated with those valves. So inspiration increases the intensity of right-sided murmurs, tricuspid stenosis, tricuspid regurgitation, pulmonic stenosis, pulmonic regurgitation. It's that easy. Expiration is the exact opposite. So in expiration, you're breathing out, your intrathoracic pressure actually increases. It increases because you want air to exit from the lungs. But on top of that, if your intrathoracic pressure is higher, it's not going to be yanking blood into the right side of the heart. It actually squeezes on the pulmonary veins and pushes blood from the pulmonary veins into the left atrium. So now you have more blood going into the left atrium. More blood is flowing across the mitral valve, and more blood is flowing across the aortic valve. That means any of the left-sided murmurs are going to increase in intensity with expiration. More blood is flowing across the mitral valve, more blood is flowing across the aortic valve. So to increase the intensity of mitral stenosis, mitral regurg, aortic stenosis, aortic regurg. That's pretty straightforward. Inspiration, right-sided. Expiration, left-sided. Done. That's it. Squat and passive leg raise. All right, so when you do a squat, you're squeezing the muscles of the lower extremities, and that milks blood up through the veins to pull more blood to the heart. So whenever you squat, you squeeze blood up towards the heart. When you have someone lay down flat and you lift their leg, gravity will pull the blood down the leg and into the abdomen up to the right side of the heart. So basically, the concept of squatting or passive leg raising is you're increasing the return of blood to the heart. You're increasing venous return. When you increase venous return, you increase the blood flow across the valves of all of the components, all the valves of the heart. You increase blood flow across the tricuspid valve, pulmonary valve, aortic valve, mitral valve. If you increase the blood flow across all of these valves, you're going to increase the intensity of all murmurs, both right and left-sided. Mitral stenosis would be increased. Mitral regurgitation would be increased. Aortic stenosis, aortic regurgitation, tricuspid stenosis, and pulmonic stenosis, and tricuspid regurgitation, all of those things would be increased. There is literally 2 exceptions. So again, squat, passive leg raise, increased venous return, increased blood flow across all valves, increasing the intensity of all murmurs except for 2 types of murmurs that you have to remember. Those 2 murmurs are hypertrophic obstructive cardiomyopathy and mitral valve prolapse, okay? We're gonna explain that in just a second. Before we do that, let's talk about the opposite of squatting and passive leg raise. Valsalva's maneuver and standing up suddenly. In Valsalva's maneuver, what happens in this is you're trying to bear down like you're trying to poop, right? You're trying to blast chocolate rain out of your Hershey Highway. And when you do that, you increase your intra-abdominal pressure and you increase your intrathoracic pressure. When you increase your intrathoracic pressure, it makes it harder for blood to actually get sucked up to the heart. So it reduces venous return. If you stand suddenly, blood is going to drop down to the lower extremities. It's not going to run up. And so that also reduces venous return to the heart. So when you're doing Valsalva's maneuver or standing, it drops venous return. It drops blood flow across all of the valves of the heart and reduces the intensity of all of the murmurs, with two exceptions: hypertrophic obstructive cardiomyopathy and mitral valve prolapse. Let's explain these exceptions and why it's a little bit different in comparison to all the other murmurs. First one is hypertrophic. It's relatively easy. So let's say that you have a patient with hypertrophic obstructive cardiomyopathy. You do the squat and the passive leg raise on them. We know that increases venous return. If you have more venous return coming into the heart, that means that you're going to fill your ventricles more. There'll be more blood in the ventricles. In hypertrophic obstructive cardiomyopathy, they have this irregular hypertrophy of their interventricular septum. That's the whole definition of it. If they have more blood in their left ventricle, it pushes that obstruction down more, stretches out the obstruction. And we say that if you have more venous return, you have more blood in the left ventricle, it decreases the left ventricular outflow tract obstruction. In other words, it decreases how much of that septum is bulging out into this area here. That right there is the left ventricular outflow tract. It's the tract where blood goes from the left ventricle into the aorta. If that big old hypertrophied area is bulging into it, it's a lot of obstruction. But if we have this blood, a lot of blood in the heart, it's stretching out the heart, decreasing that obstruction. That means that there's more blood that can exit out. So if there's more blood that can exit out of the heart, would it cause turbulence of blood flow to be as intense now? No, because there's a larger space. So if there's a larger space, there's actually going to be allowing more blood flow to flow through there. It would decrease the intensity of the murmur. The obstruction is the problem for the murmur. The more obstructed that area is, the louder the murmur, because you have to squeeze blood through a tiny little diameter area. And that's a high velocity. But if the obstruction is less, there's more space, larger diameter, more blood can flow through. That's going to decrease the intensity of the murmur. Now, think about the opposite. A patient has a hypertrophic obstructive cardiomyopathy. You have them Valsalva, or you have them stand suddenly. It drops their venous return. It drops the amount of blood that's in the left ventricle. Now I have less blood. That allows this outflow tract obstruction to be bigger, bulge in, and block the left ventricular outflow tract. I have less blood that's able to get out through that left ventricular outflow tract because I have a small diameter. There's more of an obstruction now. If there's more an obstruction, that means a smaller diameter, more turbulence of blood flow, and that's going to increase the intensity of the murmur. So think about it. More blood in the heart, you stretch out the obstruction, and that would decrease the murmur. Less blood in the heart, you can't stretch the obstruction out. The obstruction's worse. You're gonna actually do what? Increase the intensity of that murmur. Boom. All right. What about mitral valve prolapse? How does that play into this one? So with mitral valve prolapse, let's take the scenario here. You squat down, you do a passive leg raise, you increase your venous return. If you increase the venous return, you stretch out the heart, right? You cause it to get more filled with blood. Here's the easy way I think it makes sense. Think about this diagram here. You have S1, S2. We know that mitral valve prolapses, there's a click and there's a murmur. Whenever the ventricles are getting more and more and more filled with blood, it causes the ejection click to come later. The reason why is, if you have more blood in the ventricles, it's going to take a longer time for them to generate enough pressure to push that blood out of the heart and then subsequently bow in the mitral valve and regurgitate. So it takes longer. So the click will come later, and then subsequently the murmur has to be shorter. An easy way to remember that is that, again, during this time period, right before the ejection click, I like to put a heart in. If the heart is really big and large, that means it really has a high venous return. And so now there's only this small space for an ejection click and a murmur. If I have somebody who does a Valsalva maneuver or stands that has less venous return, their heart is less filled. So now it's a smaller heart. That allows the ejection click to move closer towards S1 because there's more space now. So the ejection click comes earlier and the murmur is now longer. Another way to think about it is if you have a lower venous return, less blood is in the heart, it's not going to take as long of a time for you to generate as much pressure to push blood out of the aorta and bow the mitral valve and cause regurgitation, right? So it'll come earlier, murmur will be longer. So that's the big differences. So squatting, passive leg raises, increases the intensity of all murmurs except for HCM. What does it do? It decreases it. Mitral valve prolapse, it causes the click to come Later, murmur to be shorter. Valsalva standing, what does it do? It drops venous return, so it decreases the intensity of all murmurs, except for HCM, it increases the intensity of it, and with mitral valve prolapse, it causes the click to come earlier and the murmur to be longer. Whew, we covered all of these. Let's come down now, talk about other ways that we can change the intensity of these murmurs via hand grips, amyl nitrate, and certain positioning. All right, here we go. Hand grips, amyl nitrate. What the heck does this have anything to do with the murmurs? Hand grips are really interesting. So what you can do is you can give them something to squeeze and squeeze and squeeze on. The whole point of squeezing on these different types of grips, or like maybe like, you know, those like little thingies that you can use to squeeze with, like they look like little vice grip kind of thingies. They're like the little things that help with the grip strength. When you squeeze, you actually increase the vascular resistance of your vessels. When you increase your systemic vascular resistance, that increases what's called afterload. All right, so afterload is the amount of resistance that your ventricles have to overcome to push blood out into the aorta, right? That's what we know. So whenever you have somebody use hand grips and squeezing, it increases their resistance and subsequently increases their afterload. And we're talking about left ventricle, so left ventricular afterload. If you increase afterload, what does that do to the stroke volume, guys? It drops your stroke volume. So you'll have less blood, less forward flow of blood out of the left ventricle into the aorta. You drop stroke volume, less blood is leaving the left ventricle and going into the aorta. That would be a problem if somebody has aortic stenosis. That means less blood is moving out from the left ventricle into the aorta, less intensity of that murmur. So in patients who you have hand grip maneuvers, you're increasing the afterload, you're making it even harder for that poor left ventricle to squeeze blood out of. And that's going to decrease the flow even more. Less blood is flowing across that stenotic valve, less intense aortic stenotic murmur. The other way to look at this is if the pressure, okay, think about it like this. If you have somebody here who has this aorta, right, and their pressure inside, they have a higher blood pressure in the aorta and a lower blood pressure here in the ventricle, or you just have, let's just say in general, you have a very high pressure inside of the aorta, and this valve is incompetent, it's not working well. Blood is going to just smash down from the aorta into the left ventricle so easily because the pressure in this aorta is super high, because if you're, again, increasing resistance, you're increasing afterload, you're increasing the pressure in the aorta. That means the left ventricle has to work harder to push blood out into it, but also it means that any blood that is in this aorta, if there's not a valve blocking the blood flow from going back down, guess what? It's going to shoot back down, and it's going to cause more retrograde blood flow if the pressure here is higher. So anything that's causing regurgitation of blood flow would be worse, right? Yes. So it increases the aortic regurgitation murmur because the pressure here in the aorta is so high, more regurgitated blood flow occurs because of the higher afterload. The other thing to think about, here's the other thing. If you have a low stroke volume, what happens to the amount of blood that leaves the heart? That means less, right? But that also means that you have more blood in the heart. If you have a low stroke volume, we know a low stroke volume means that you're going to have more blood in the heart because not as much left. So now I have more blood sitting in my heart due to a low stroke volume. And so we can say that this is called an increase in left ventricular end diastolic volume. I'm going to have more blood in the ventricles now throughout at the end of diastole, okay? If I have more blood in the ventricles, we can kind of think about this, more blood in the ventricles can stretch out the ventricles. That can decrease the dynamic obstruction. What did that do to the murmur for HCM? It decreased it. So this could decrease the intensity of the hypertrophic obstructive cardiomyopathy murmur because I have more blood in the ventricles because less blood left, that's stretching out the heart, stretching out the obstruction. In the same way, mitral valve prolapse, think about a big old ventricle, the ejection click has to, there's only so much space, ejection click has to come later and the murmur has to be shorter in mitral valve prolapse. And then the next thing is, think about this, you have more blood in the left ventricle. If you have more blood in the left ventricle and this mitral valve is damaged, when the left ventricle contracts, it's going to push a ton of blood back into the atria during systole. So it can increase the mitral regurgitation murmur. I know this is a lot. So to quickly sum these up again, Hand grips increases resistance, increases afterload. That decreases forward flow, decreasing stenosis and murmur, aortic stenosis murmur. It increases the pressure in the aorta. So now, if there is an incompetent valve, there's going to be more retrograde or reflux, worsening aortic regurgitation murmur. If there's actually less stroke volume, because you're not able to get as much blood out, now there's going to be a larger volume of blood in the ventricles that's going to stretch out the dynamic obstruction in HCM, decreasing its murmur, stretch out the ventricles, causing the click and mitral valve prolapse to come later and the murmur to be shorter. And last but not least, if there's more blood in the ventricle, if you're ejecting blood across an incompetent mitral valve, that's more blood flowing across that incompetent valve, increasing the mitral regurgitation murmur. Okay, all we're going to do now is the exact opposite. This should make it sense and it should be a recap. Amyl nitrate is a drug that actually vasodilates vessels. So it's going to cause vasodilation. If you vasodilate, you decrease systemic vascular resistance. So this hand grip increases systemic vascular resistance. Amyl nitrate decreases systemic vascular resistance. Increase in systemic vascular resistance increases afterload. A decrease in systemic vascular resistance decreases afterload. There's less work now that the left ventricle has to do to push blood out in the aorta. Lower afterload means higher stroke volume. More blood is leaving the left ventricle and going into the aorta. If more blood is passing from the left ventricle into the aorta, that means that we're having more forward flow across the stenotic valve. That means I increase the intensity of stenotic murmurs, aortic stenosis. If my afterload in my aorta is lower, that means that there's less pressure in the aorta. That means even if there is an incompetent valve there, less retrograde flow is going to occur because there's actually a lower pressure in the aorta. So not as much is going to reflux. So if there's not as much reflux from the aorta into the left ventricle, that decreases the aortic regurgitation murmur. If I have a high stroke volume, I'm going to have less blood in my ventricles now. That's not going to stretch out my obstruction as much. If I don't stretch out my obstruction as much, I cause my hypertrophic murmur to become increased. If I don't have as much blood in the ventricles, I cause my click to come earlier and my murmur to be longer in mitral valve prolapse. And if I have less blood in the ventricles and I have an incompetent or poorly sealed mitral valve, less blood is flowing across that incompetent or poorly sealed valve, decreasing the mitral regurgitation murmur. Whew. That was a lot, right? I know, but this was probably the tough one. If you guys can get this one down, I think a lot of these murmurs are pretty straightforward, the maneuvers. This is the tough one. All right, these are the last ones, and I think these are probably the easiest ones to remember, along with inspiration and expiration. You can also increase the intensity of a maneuver, of a murmur, by having a patient lean forward. So if you have them sit up and lean forward, what you do is you bring the aortic valve closer to the chest wall, the aorta and the aortic valve. So if they have any lesion of the aortic valve, it's going to be increased in intensity when you have them lean forward. So aortic stenosis and aortic regurgitation murmurs will be increased if you have them lean forward. The other thing is if you put them in what's called the left lateral decubitus, you have them lay on their left side, and you listen towards the apex, that brings the mitral valve closer to the chest wall, increasing the intensity of any murmurs that are occurring near or at that mitral valve, such as mitral stenosis, mitral regurgitation, and mitral valve prolapse. Straightforward, right? Okay, just get this one down, and I think the rest of these maneuvers are pretty straightforward. Let's hit this off talking about the last diagnostic investigation test that we should do and talk about treatment and complications. All right, engineers, so here we go. We're at the last part of diagnosis. So the diagnosis of valvular heart diseases are obviously, you have to take into consideration the murmurs. Those are probably going to be the biggest things to think about for your exam, okay? Especially the maneuvers. So know where the murmur is, the quality, the configuration, when it's in systolic or diastolic type of murmur, and know the maneuvers that increase or decrease the intensity. But obviously the gold standard diagnostic test that's going to show you the murmur, tell you how intense the murmur is, how bad the murmur is going to be echocardiography. Okay, that's going to be the best test. So whenever you hear a murmur, you're going to need an echo to confirm that that is the murmur that you think it is, and then determine how severe it is, and then also it can guide management. So if you have a very terrible type of murmur, you might need to actually do some type of surgical procedure for these patients. So you have a patient with a murmur, you think it might be mitral regurgitation, you go and get an echo. The best type of echo test that you would want to do for these patients first, right when they come through the door, they're going to be getting a transthoracic echocardiogram. But the sensitivity and specificity for this, for picking up some of the murmurs, isn't as great as a transesophageal echocardiogram. So that would be your kind of best and confirmatory test. So for example, you have a patient, you get a transthoracic and you say, I think there might be an aortic regurgitation murmur, but I can't really tell if it is that bad. Let's get a transesophageal echo and then definitely confirm and actually completely get a good look at that aortic valve and see if there is definitely an aortic regurgitation murmur, see the size of the regurgitation jet, etc. Okay? So this is the best kind of thing that you need to do. You need to get an echo to confirm this test. This is really the gold standard test. You can do an initial transthoracic. A confirmatory best case test would be a transesophageal. Now, what you're looking at and what you can gather from the echo is actually a lot of information. They used to say cath, catheterization and cardiac catheterization would be one of the best tests. It technically is. It would be the best test, but it's super invasive. And we can actually, for the most part, extrapolate and kind of estimate some of the things that you can see on cardiac catheterization with echo. And so we prefer to do echo. Cath is definitely going to be the best, super invasive, and we don't want to have to do that unless it's absolutely necessary. So echoes are usually a good test. What can we get from that? We can actually estimate the valve diameter. So if someone has a really bad valvular stenosis, we can see how much of that actual diameter is left at the aortic valve orifice. Okay, we can also determine the velocity across the valve. So if there's super high velocities, there may be a very stenotic and low diameter orifice there. We can determine the pressure gradients across the valve, which is very important. We can also assess the ejection fraction to see if this actual regurgitation or stenotic type of lesion is causing heart failure. And last but not least is we can see the regurgitation jet. We can put on color Doppler and see how much of the regurgitation jet there is, how large, how wide the regurgitation jet is, and these are important things to take into consideration. All right, so once we've gotten our echo, transthoracic first, transesophageal is confirmatory. We can estimate a lot of things from this. This will definitely tell us if we have a stenotic or regurgitation murmur and how bad it is, and it can guide our treatment. When we're talking about the treatment of valvular heart diseases, there's a basic concept of these. A lot of this is heart failure, right? We talked about if it's your mitral aortic lesions, stenotic or regurgitation, it can lead to pulmonary venous congestion. You're treating the actual pulmonary edema primarily, and maybe they have hypotension in these cases. But primarily, you're treating their heart failure. And so sometimes for these patients, it's fluid restriction, it's sodium restriction, diuresis for symptomatic control. For the right-sided heart failure, like in tricuspid and pulmonary, they may have JVD, they may have ascites, they may have hepatomegaly, pedal edema, and again, it's fluid restriction, sodium restriction, and diuresis as symptomatic management. Sometimes you may have to throw in other things if their blood pressure can tolerate it, like beta blockers and ACE inhibitors and things of that nature that have been shown to reduce mortality in patients who have heart failure. But in these patients who have very severe valvular heart diseases, heart failure management may not be enough, and sometimes we may have to do something called surgery. Okay, so the surgical options, what are they? When are they preferred? And then we'll go over them specifically in mitral and aortic diseases. What are the true indications? So the types of surgeries that you want to consider is balloon valvuloplasty. This one's actually really cool. It's preferred for stenotic lesions. So aortic stenosis, mitral stenosis, but I would remember it more specifically for mitral stenosis. So balloon valvuloplasty, I want you to think mitral stenosis, but in general stenotic lesions. What we do is we take a catheter, we have a balloon, okay? You run in through the actual stenotic valve, and then you inflate the balloon and stretch out that stenotic valve, that fibrotic valve, to create more of a space that you can have blood flow being able to eject across the left atrium to the left ventricle, or from the left ventricle into the aorta. Pretty much very simple, right? So again, we prefer to do a balloon valvuloplasty for stenotic lesions, way more preferred for mitral stenosis, less common for aortic stenosis, okay? That's that. Now, when would we do a valve repair? So if they have a damaged valve, or we can repair that, or if the valve is so damaged that we can't repair it and we have to replace it, what would be the particular indications? Well, before we say that, we actually have to know two types of valve that we can actually give this patient. One is we can put what's called a bioprosthetic valve. It's like a porcine valve or a bovine valve. It's from an animal, and we actually utilize that and either replace that from their original native valve. One of the big things to remember for bioprosthetic valves is they don't have a very long life, okay, span. Generally maybe like 10 years and you have to replace it. So for patients who are like older, that might be a better regimen. Also, for bioprosthetic valves, you don't have to anticoagulate them. They're not as highly thrombotic. So for patients who are at a high risk of bleeding and you don't want to give them like a mechanical valve, this might be a good patient population to put them on, as those who are at high risk of bleeding wouldn't be able to tolerate anticoagulation from a mechanical valve. The other one is the mechanical valve. Now the mechanical valve is actually going to have a good lifespan. It's usually like a lifelong. So it's going to be able to be good for those patients who are young, who have a long life expectancy, hopefully. And also, they have to be anticoagulated. It's a very thrombogenic type of valve. So they need to be on anticoagulation. So if patients who have AFib or they have a low risk of bleeding, that would be a valve that would be preferred for those patients. Now, we know the two types of valve that they can replace, or we can just repair the damaged native valve. What would it be used for? Stenotic lesions that did not respond to balloon valvuloplasty, or you couldn't do the balloon valvuloplasty because it was contraindicated, or they have a regurgitant lesion, a severe regurgitant lesion. And we're going to talk about these now with these particular conditions. It's not as common for us to really deal with pulmonary or tricuspid lesions and talk about their surgical and heart failure management. It's more common for the left-sided heart valve problems. So we'll focus here on aortic stenosis, aortic regurg, mitral stenosis, and mitral regurg, and what are their indications for surgery. Okay, aortic stenosis, the indications of why you would get a surgery to replace the valve or repair the valve. And you know, we can actually do this two different ways. It's pretty interesting. We can open them up. So we can open up the chest and do it. So we call that a surgical procedure to repair or replace their aortic valve. Or we can do what's called a transcatheter aortic valve replacement. We can actually thread a catheter through like the femoral artery or through like a radial, in that nature, and then we can actually come up to the aortic valve endovascularly and then replace or repair that valve. So it's pretty cool. So that's the ways that you could do that. But what are the indications? Generally, whenever in aortic stenosis, the little narrow, there's a significant narrowing of the aortic valve, right? So if you were to kind of have here the aortic valve, it's super, super narrow, that little space that I want to squeeze blood through, okay? So we call that the aortic valve area. When the aortic valve area is less than 1.5 centimeters squared, it's getting towards that like moderate to severe time. And whenever it's at that bad and their ejection fraction is dropping, meaning that the stenosis is so bad, it's causing the left ventricle to actually become dysfunctional and its EF to drop, that's a particular reason. Or if they have any symptomatic issues, they have dyspnea on exertion, syncope on exertion, or angina on exertion, these are also indications. So having a very small aortic valve area, very stenotic, very small orifice for blood to squirt through, their EF is low, they have SAD symptoms, or they are getting a surgery for something other than aortic stenosis, like they're getting a CABG. That would be a good reason to go and get an actual repair or replacement of their aortic valve, okay? So remember those particular indications. Small valve area, low EF, again, SAD symptoms, and getting a surgery for something other than the aortic stenosis, like a CABG, is a good reason. Okay, what about mitral stenosis? They have a stenotic valve. We said for these, it's preferred to do balloon valvuloplasty. You try the balloon valvuloplasty and it fails, they may need to get a replacement or repair. Or they have a contraindication that they can't get the balloon valvuloplasty. What would that reason be? Because they have so much calcifications of their mitral valve that trying to balloon that is likely to fail. Then we wouldn't even do it. So if there's excessive amounts of calcification on the mitral valve, we don't even do the balloon valvuloplasty. We may just have to go straight to the surgical procedure. So that's a big thing to remember. If they failed it, or they have heavy, heavy calcifications. So what are the indications? And generally this is surgical. It's not really transcatheter associated. So what we would say is anytime they're symptomatic. So they have pulmonary edema, so dyspnea, orthopnea, paroxysmal nocturnal dyspnea, they have any kind of hypotension because they have associated AFib, and their mitral valve area is less than 1.5 centimeters squared, that little tiny space where blood is supposed to be squeezing through here is super, super tiny, then they need to be able to get that mitral valve replacement or repair. But we prefer the balloon valvuloplasty in all scenarios. If it fails or it's contraindicated and they have a mitral valve area less than 1.5 centimeters squared, and they have heart failure symptoms, left heart failure symptoms, boom, we have to give them a mitral valve replacement. Okay, aortic regurgitation, what will be the indications for this one? So we only do this one open. We can't do it the transcatheter aortic valve replacement for this one. So we do it open. Remember, aortic regurgitation they're filling with lots of blood. Remember, there's lots of regurgitation of blood into the left ventricle. So they're going to be accumulating that blood. And what did I say in chronic cases they will do to accommodate that blood? They will dilate. When they dilate, the actual diameter of their ventricles gets gargantuous, gets huge. Whenever that dilation causes the diameter to be greater than or equal to 50 millimeters, we are saying at this point, it is too severe and we really need to consider surgery. If their EF is dropping less than 50, that might sound crazy, but in patients who have aortic regurg, their ventricles are super hyperdynamic. They're pumping so hard. So if their ejection fraction drops less than what's considered to be normal, that is severe and they need to go to surgery because that valve is actually causing them to go into heart failure very quickly. It should naturally be greater than 50%, like 60, 65, 70% it should be in aortic regurg. If that drops down, their left ventricular dysfunction is starting to occur and we need to get them to surgery. If they have any symptoms of heart failure, so left heart failure, EF is dropping, their left ventricle is super dilated, or they're getting cardiac surgery for something other than the aortic regurgitation, such as a CABG, again, that is an indication to get aortic valve replacement via surgical open procedure. Okay, mitral regurgitation, same kind of concept. Again, you're pushing blood into the left atrium because of an incompetent valve, but that blood is going to come right back down. It's going to cause excessive filling of the left ventricle, and it's going to dilate. If it dilates so much to the point where it's greater than or equal to 40 millimeters, that's considered to be severe. If their ejection fraction is going to be less than 60%, so we say 30 to 60% in general, that's severe. And if they have any left heart failure symptoms, that is consideration for a patient needing to get a mitral valve replacement. Okay, so again, I hope all of these make sense. I know it's a lot of numbers, but what I really want you guys to understand here is anytime someone has a very small aortic valve area, their EF is dropping, okay, and they're having any symptoms or getting a cardiac surgery, they should get an aortic valve replacement for a stenosis. If their ventricles are super dilated, EF is dropping, they have symptoms, again, they need to be able to go and they're getting a surgery for other than aortic regurgitation, they need to get the surgery. Mitral stenosis, the valve area is getting small, they're symptomatic, and they failed. This is the big one. They failed the balloon valvuloplasty, or they had a contraindication to it. Mitral regurg, ventricles are dilating, their EF is dropping, they're becoming symptomatic. They need to get a replacement or repair. Now that we covered these, once we've actually given them a prosthetic valve, whether it be a bioprosthetic valve or we've given them a mechanical valve, what can happen if these valves start malfunctioning? We need to talk about that. All right, let's wrap this bad boy up. We got prosthetic valve dysfunction. You've given them a valve. You've replaced their damaged valve because they had mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation. They met the criteria. What can happen sometimes? Sometimes that actual prosthetic valve can actually cause a regurgitation type of dysfunction, or it can cause a stenotic dysfunction. We have to understand the difference between these two. With a regurgitant type of dysfunction, there's two different types of leaks that you can have here. So one is whenever you put this prosthetic valve in, and they're supposed to be like sewn into like the wall here. Let's say that this is for the aorta, it's like supposed to be sewn in. The sewing kind of dehisces or separates from the wall by which it's supposed to be sewn into. And now there's a space by which blood can actually, it's supposed to flow through the valve, right? Only in one direction. But now blood is actually, we don't want it to actually go this way, but we want the blood to flow this way. But this will close naturally, but there's a little space here due to the dehiscence. Now that blood can flow right back into the left ventricle through that little area on the side of the valve. What do we call that? Paravalvular. There is a paravalvular leak due to the prosthetic valve dehiscence. So you're dehissing the actual wall from the annulus now. There's the sewings that aren't having them sewn well together to the wall. Now because of that, blood can just completely backflow. You can see this more particularly with the mechanical valves as compared to the bioprosthetic valve. So for paravalvular leak, it's the dehiscence of the prosthetic valve away from the wall, and you see this more with mechanical valves than you do with bioprosthetic valves. The transvalvular leak, usually what happens is there's some type of destruction of the bioprosthetic valve, or there's like a thrombus that you form on top of this valve that alters the ability of the valve to close properly. So you have a thrombus that's on that bioprosthetic valve that's affecting the valve from being able to close properly, Or you have a destruction of the bioprosthetic valve where it's been chewed away and now there's a space for blood to just leak right between. Now this can happen right through where it's not supposed to go through, straight through the valve, transvalvular leak. This would happen with bioprosthetic valves that have been chewed away due to some type of degeneration. Maybe they have infective endocarditis. Or they have a thrombus that's on the valve and it's not allowing the valves to close properly as they should. That can also cause a regurgitation jet. This is a transvalvular leak. So paravalvular, mechanical. Also on the side due to dehiscence. Transvalvular, bioprosthetic, due to eating away of the bioprosthetic valve or a valve thrombus that isn't letting the valve close properly. Boom, roasted. What about the stenotic valves? The stenotic prosthetic valve would also be due to a valve thrombus. So imagine you have a valve thrombus and it's not allowing the valve to be able to open up properly because it's obstructing it. So imagine you have like a thrombus right here on top of the tip of the valve, the prosthetic valve, and blood is supposed to be moving between those. Now you're obstructing the blood flow and making it harder for the blood to get out of the left ventricle into the aorta, let's say. That can happen with these prosthetic valves. So if a valve thrombus is there, it can actually prevent the valve from closing properly, but it can also make it harder for the blood to be able to get out if it's obstructing the outflow tract. That's one particular reason. The other one is if you actually cause the valve cusps of a bioprosthetic valve, if it starts actually not working to be able to open up properly for some particular reason, like there's a cusp malfunction and they're failing to open, that can also cause the prosthetic valve to become stenotic. Regardless, I want you to focus more on these, less on this one, but either way, if you have a concern for their prosthetic valve not working, it's dysfunctional, what are some of the big clinical features to think about? Let's say that they had that actual replacement and they didn't have a murmur. All of a sudden, they have a new murmur. That's a concerning finding. Next one. This one's interesting. They actually changed the name recently. It used to be called MAHA, macroangiopathic hemolytic anemia. Sometimes now they call it TMAs, thrombotic microangiopathies. But what happens is, with this one, if you have a very stenotic prosthetic valve, imagine red blood cells trying to flow through that little area of stenosis. It can rupture these red blood cells. If it ruptures the red blood cells, you can have all these decreasing in your number of red blood cells and lots of bilirubin in the blood, lots of LDH in the blood, and a bump in your reticulocyte count. So these are things to be thinking about. So if you have a new murmur, which they did not previously have, and you look at their blood work and they have a decrease in their number of red blood cells and hemoglobin and an increase in their bilirubin and in LDH, that could be one finding. The other thing is if these dang valves, especially the regurgitant ones, they stop working, and you previously had a person who was doing okay, then you got the prosthetic valve, they now have acute onset left side heart failure with pulmonary hypertension, they have pulmonary edema, they have hypotension, all of those findings, that should be very concerning for their prosthetic valve failing, and now they're in complete heart failure. And the last one is because of these heart valves malfunctioning, sometimes it can increase their risk of forming thrombi onto them. So if you have a valve that becomes damaged in any way because of a regurgitation issue or a stenotic issue, now they're damaged, they're susceptible for little thrombi forming onto them and flicking off and causing strokes. So these are the big things to think about. But I think the most important one is a patient with a new murmur and new heart failure who had just a prosthetic valve placed recently. That would be a concerning finding for prosthetic valve dysfunction. Engineers, we did it. We covered a behemoth of a topic, and that being valvular heart diseases. I hope it made sense. I hope that you guys enjoyed it, and as always, until next time.